Oops. Antipsychotic, atypical antipsychotic. Malignant hyperthermia. Wait, no, he is in the basketball practice. And look at the temperature. An antipsychotic, dantrolene, malignant hyperthermia is a drug of choice is dantrolene. It happens after inhale anesthetic. Like, okay, and this, sorry, yes, dantrolene is NMS. Oh, sorry, neuroma, like atypical antipsychotic can cause neuroleptic malignant syndrome, and the dantrolene can be used on that. And in malignant hyperthermia, it is also used. So, okay, this patient with hyperthermia disorientation, and this patient with hyperthermia and disorientation and hypotension, hypotension that occur during prolonged exercise has exertional heat stroke is heat related illness characterized by a core temperature more than 40 associated with CNS dysfunction, altered mental status, seizure. These fracture help to differentiate exertional heat stroke from heat exhaustion. No CNS dysfunction, however, no CNS dysfunction, hyperthermia more less than 40 degrees Celsius, 104 degree Fahrenheit. Exertional heat stroke typically occurs in otherwise healthy persons who are exercising in extreme heat and high humidity, which interferes with the body's ability to undergo evaporate cooling from the sweat. Other risk factor for exertional heat stroke include obesity, poor exercise tolerance, limited acclimatization uh, concurrent uh, or concurrent weather conditions, and certain medications, that is anticholinergic, antipsychotics such as quetiapine that interferes with thermoregulatory mechanism. Other signs and symptoms of exertional heat stroke include hypotension and tachycardia, hyperventilation, flushing, and diarrhea. Diaphoresis may occur depending on volume status, or oxidative stress and tissue hypoxia can result in rhabdomyolysis. Rhabdomyolysis, disseminated intravascular coagulation, and end organ dysfunction, renal or hepatic failure, or pulmonary edema. First line management involve rapid cooling with ice water immersion. If an ice water bath is not available, alternative cooling methods cold water shower should be used because EHS is primarily due to impaired thermoregulatory mechanism rather than cytokine production. There is no role For antipyretic therapy, acetaminophen morbidity and mortality are directly associated with the duration of hyperthermia. Therefore, and correction of fluid resuscitation and correction of electrolyte abnormalities should be considered after cooling has begun. Okay. Yes, exertional heat stroke risk factor is strenuous activity during hot and humid weather. During hot and humid weather, dehydration, lack of physical fitness, obesity, medication, anticholinergics, insertion of anticholinergics, antihistamine, phenothiazine, tricyclic antidepressant, and antipsychotics. Anticholinergic, antihistamine, phenothiazine, TCA, antipsychotic. Clinical manifestation: core temperature more than 40 degrees Celsius, 104 degrees Fahrenheit, with CNS dysfunction, altered mental status, seizures, organ or tissue damage, renal or hepatic failure, DIC, acute respiratory distress syndrome. Management: rapid cooling, ice water immersion preferred. Rapid cooling, ice water immersion preferred. Can consider high flow, cold water dousing, ice, wet towel rotation, evaporative cooling, fluid resuscitation, electrolyte correction, management of end organ complication. No role for antipyretic therapy. Okay, this is CGD, dihydrorhodamine flow cytometry is abnormal. It is preferred, and NBT is less sensitive. Mm. And another is catalase positive organism, Serratia is positive, Serratia marcescens. It's pigment producing actor. Okay, this patient with recurrent skin abscesses and abnormal dihydrorhodamine test consistent with CGD. CGD is caused by a gene defect in the NADPH oxidase enzyme complex, which results in inability to form superoxide radicals. Mm, and impair intracellular killing in phagocytes. Patients with CGD classically have recurrent severe cutaneous and pulmonary infection with catalase positive bacterial and fungal organisms, Staphylococcus cereus, Aspergillus. Other common causes include suppurative adenitis and osteomyelitis. Platelets and B and T cell concentration is normal. Platelet and B and T cell concentration is normal in CGD. Leukocyte count may be normal. Leukocyte count may be normal or elevated during acute infection. During acute infection, initial evaluation on suspected CGD includes oxidative burst such as dihydrorhodamine flow cytometry or nitro blue tetrazolium. Dihydrorhodamine is usually taken up by phagocytes and fluoresces green when oxidized by NADPH oxidase to rhodamine. Negative fluorescence after stimulation is consistent with CGD, and the diagnosis is confirmed by gene testing. Patients with CGD should receive antibiotic prophylaxis, TMP, SMX, antifungal prophylaxis with itraconazole. Severe phenotypes, uh, severe phenotypes from immunomodulation with IGRA injection, interferon gamma injection, immunomodulation. Okay. One thing I want to, uh, okay, I want to tell you, like in the box, like Brutons. No, no, no. Mm, in do you have a USMLE inner circle? Okay, in inner circle, if you look at the box of X-linked acromegaly and CVID, in short, like in short subjects, you can easily find in short subjects. Uh, uh, okay, look here, the difference between in these two. Like look at the CVID diagnosis, no response to vaccination. But in Brutons, so decrease response to vaccination, decrease immunoglobulin and antibody response to vaccination. So this may be one difference. So we can add this, like there is no response to vaccination, like complete absence of response to vaccination in CVID and low or decreased response in. Okay, yeah. So I want to add that. Okay. Because these two is very similar and tough, very tough to diagnose. Yes, age is a vital factor. Yes. So Brutons for babies and for adulthood or childhood. Okay. Toxic alcohol ingestion, methanol or ethylene glycol. Um, this patient with encephalopathy, somnolence, disorientation, bilateral somnolence or disorientation, bilateral flank pain has significantly decreased serum bicarbonate consistent with metabolic acidosis, an elevated anion gap, anion gap metabolic acidosis. These findings, in conjunction with AKI and urine calcium oxalate crystal and hypocalcemia, raise the suspicion of ethylene glycol toxicity. Ethylene glycol is a toxic alcohol commonly. Ethylene glycol is a toxic alcohol commonly found in antifreeze and brake fluid. When ingested, it mimics ethanol intoxication. Ethylene glycol is metabolized. Ethylene glycol is metabolized by alcohol dehydrogenase into toxic compound to glycolic acid or oxalic acid. Accumulation of these organic acid causes agma and organ damage. Agma and organ damage, including nephrolithiasis, calcium oxalate crystal, and AKI direct nephrotoxicity. Treatment primarily involves the following three components: alcohol dehydrogenase inhibition to prevent formation of toxic acid. The preferred antidote is ethylene glycol. Toxicity is famotidine, but ethanol can be used if famotidine is unavailable, and correction of acidemia by IV sodium bicarb to decrease tissue perfusion and tissue perfusion of toxic compounds, hemodialysis to rapidly remove free from toxic organic acid and parent alcohols, particularly in the presence of agma and organ damage. Okay, okay. This is large local reaction. In large local reaction, the exaggerated area more than the exaggerated area approximately 10 centimeter of swelling in duration and redness on these patients hand after a sting by a member of the Hymenoptera species B. Yellow jackets wasps is called large local reaction more than 11 centimeter. Reaction to Hymenoptera evaluation range from mild to severe, with approximately 10% of the individual developing large local reaction. Large local reaction like allergic response and Ig mediated pain, swelling, and erythema begin at the site of the sting within minutes and can present in size to approximately 10 centimeter and more. Symptoms usually climax from 24 to 48 hours. Symptoms usually climax between 24 to 48 hours and resolves over a few days. To be considered a large local reaction, the area of exaggerated swelling and erythema must be contiguous with the site of the sting. Treatment options include antihistamine, topical or oral steroid, anti-inflammatory drugs. Patients with large local reaction may be at higher risk of developing future systemic reaction 3 to 16%, but prescribing an epinephrine autoinjector remains debatable. Okay, yes, systemic anaphylaxis is a sudden life-threatening IgE mediated response to certain substances. These patients' reaction is IgE mediated but local, not systemic. Also, systemic symptoms seen in anaphylaxis, vomiting, airway swelling, respiratory difficulty, shock are absent in this. Toxic reaction occur in patients. Toxic reaction occur in patients, usually infants or the elderly who have sustained envenomation from numerous stings by members of Hymenoptera species. Symptoms: nausea, vomiting, diarrhea, seizures, fever are due to direct vasoactive properties of the venom. These patients lack systemic symptoms, no vomiting or fever, and experience a single sting. Okay, yes. Large local reaction, La- large local reaction often due to bites from Hymenoptera species, exaggerated IgE mediated local allergic response 10% of stung individual associated with associated with possible increased risk of future symptoms, significant 10 centimeter or more localized swelling, erythema, and warmth, swelling, erythema contiguous with the site of the sting and develop within 24 hours, peak within 24 to 48 hours, and resolve within 5 to 10 days. Cold compression, oral or topical steroid, antihistamine, and anti-inflammatory drug. Large local reaction. Large. Large local reaction, mainly the size and no respiratory discomfort. Animal bite cannot cause like food anaphylaxis. 2 to 3 millimeter, maybe it is normal. As far I think, like 4 millimeter is you, you search. I don't remember also. Four, yes, maybe. TCA cause dilated pupil. It is very complicated. Caustic cleaning product like Harpic, like toilet cleaner. Is it?
Mm,
Okay. This patient is conscious and alert with erythematous ulcerated. This patient is conscious and alert with an erythematous ulcerated oropharynx, leading to difficulty swallowing his secretion drooling. This presentation is most consistent with caustic injection. Mucosal injury results from local contact. Mucosal injury results from local contact with the caustic substance rather than from systemic absorption. Therefore, patients are conscious and alert but often have severe pain. Oropharyngeal damage lead to ulceration and erythema. Laryngeal edema can cause hoarseness and airway compromise. Esophageal damage can lead to dysphagia. Odynophagia, difficulty handling secretion, heavy drooling in patients with alkaline caustic ingestion, gastric damage, abdominal pain is less likely, probably due to partial neutralization of alkali by stomach acids. Full thickness necrosis of the esophagus can lead to perforation, results in either mediastinitis or peritonitis. Esophageal stricture are the most common complication. and occur weeks to months after injection. Many patients, approximately one third, develop esophageal squamous cell carcinoma years after initial injection. Caustic. Okay, I don't know why I am done. Okay, the diphtheria, tetanus, and acellular pertussis vaccine, a combination of vaccine containing acellular pertussis antigen containing a acellular pertussis antigen with diphtheria and tetanus toxoid. Combination of vaccines are safe, effective at preventing infection and beneficial in reducing the number of needle sticks requiring in decreased pain and improved compliance. Child should receive 5 doses of inactivated DTaP vaccine at age 2 4 6 months, 15 to 18 months, and 4 to 6 years. The risk of an adverse reaction to DTaP vaccine is low, generally include minor erythema swelling at the site of the infection, seizure triggered by fever, or by pertussis vaccine component. Pertussis vaccine component is rare, typically short, less than 5 minutes, and self-limited as in this child. Patients with a family history of febrile seizure or epilepsy may be increased risk. However, neither personal nor family history of seizure is a contraindication to immunization, especially Uncomplicated seizures, especially uncomplicated seizure following vaccine administration, is not a contraindication to future vaccination. The benefit of DTaP vaccination, especially in the setting of pertussis outbreak, outweighs the unlikely the risk of significant side effect. The DTaP vaccine is contraindicated in few circumstances. When anaphylaxis develops following DTaP administration, the patient should not receive the future doses. So anaphylaxis, in, in addition, in addition, unstable neurologic disorder, infantile spasm, uncontrolled epilepsy, and encephalopathy. Within a week of DTaP vaccine administration are contraindication. The combination vaccine, as a result, diphtheria, pertussis, tetanus toxoid should be administered without pertussis. I don't get it. Yes. So seizure persists more than 5 minutes, like febrile seizure. But initially, look, the seizure triggered by fever or by pertussis vaccine component is rare and is typically short, less than 5 minutes. It is self-limited. So in this case, they told to give the vaccine. But if it is more than 5 minutes, like chance of having epilepsy, then we should not give. Okay. Looks like OPC. Looks like OPC. Or organophosphate. Yes. Sorry. No, no. OPC full form is organophosphate compound. In our country, if you say OPC, that is all about. So people understands the OPC word. Very common. This poisoning is very common, and like snake poisoning is common. Snake poisoning not happens in like our city, like some city has lots of snake poisoning. Okay. This patient with bradycardia, meiosis, and excessive, this patient with bradycardia, meiosis, and excessive secretion like diaphoresis, wrong kind drooling, and have evidence of cholinergic toxicity, likely due to accidental or intentional exposure to organophosphate pesticides. Organophosphate inhibit acetylcholinesterase, leading to hyperstimulation of the muscarinic. Mnemonic is dumbbells and nicotinic muscle fasciculation, weakness, paralysis, cholinergic receptor. Management of organophosphate toxicity include stabilization, airway, breathing, circulation, decontamination to prevent continued exposure, and removal of solid cloths. Removal of solid cloths. Where I am. Removal of removal of soil cloths, irrigation of skin, and reversal of cholinergic hyperstimulation. Atropine, a competitive inhibitor, and acetylcholinesterase at the muscarinic receptor should be given immediately, leads to a resolution of muscarinic symptom bronchospasm. Because atropine does not act on the nicotinic receptor, patients with evidence of neuromuscular dysfunction should then receive pralidoxin, a cholinesterase reactivating agent that can relieve both muscarinic and nicotinic effects. Joint pain right 2 days ago. Maybe. Yes. It is serum sickness like reaction. Okay. This patient's fever, arthalgia, arterial rash, and diffuse lymphadenopathy in the setting of recent beta-lactam therapy suggests serum sickness-like reaction. Although serum sickness-like reaction and serum sickness share similar clinical presentation, the underlying triggers and mechanism differ. Serum sickness is triggered by foreign protein and in antitoxin, antivenoms, or monoclonal antibody, and is marked by generation of high titer immune complex deposition in tissues and significant complement activation. In contrast, serum sickness like reaction is typically triggered by beta lactam, amoxicillin, or sulfur drugs, and is brought to be genetic deficiencies in eliminating the metabolic byproduct of these medications, which leads to heptin-mediated cytotoxic T cell injury or direct cytotoxicity. Serum sickness-like reaction is most common in children and usually presents 5 to 14 days after medication. After medication initiation, most patients have mildly pruritic arterial rash that presence that persists more than 24 hours. Significant multi-articular joint pain is usually present. Examination usually reveals pain with joint movement, but signs of arthritis, joint warmth, swelling, erythema are usually absent. Low-grade fever and generalized lymphadenopathy often occur. Symptoms of serum sickness like reaction resolve completely over several days as the medication is eliminated by mononuclear phagocyte system or by metabolic pathway. Serum sickness like reaction, however, the inciting medication should be discontinued in those still taking it. Although future exposure may not cause recurrent symptom, the drug should be avoided when possible. Okay, looks like I am reading the newspaper. Okay, serum sickness. Foreign proteins in antivenom, antitoxin, or monoclonal antibody. Immune complex is high titer. Complement activation. Serum sickness complement activation is extensive, usually 5 to 14 days after exposure. There may be fever, arthalgia, urticaria, and spontaneous resolution. And serum sickness like reaction due to medication like cefaclor, penicillin, and trimethoprim sulfamethoxazole immunocomplex mild on none, complementation mild on none, like 5 to 14 days of exposure, fever, low grade arthalgia, urticaria, spontaneous uh, resolution, spontaneous resolution after discontinuation of the drug. So difference is like fever and immune complex like complement activation, or serum sickness is like antivenom antitoxin, okay. Okay, this patient with recurrence of anaphylactic symptom, hives, wheezing, emesis after initial resolution is having a biphasic anaphylactic reaction and should be treated with additional doses of intravascular epinephrine. Anaphylaxis is an acute life-threatening IgE-mediated type 1 hypersensitivity reaction characterized by allergic symptoms affecting two or more than two organs or sudden hypertension after allergen exposure based in it often resolves quickly and completely after epinephrine administration. However, symptoms may occur or persist despite treatment. According to the following patterns, biphasic anaphylaxis as seen in this patient is characterized by initial anaphylactic reaction followed by asymptomatic period, typically 1 to 30 hours, then recurrence of the symptom, protract anaphylaxis, Less commonly is characterized by anaphylactic symptom lasts hour or despite treatment. Patients with biphasic or protracted anaphylaxis should receive additional IM epinephrine if symptom persists after 3 IM doses. IV epinephrine infusion may be required. Adjunct therapies may target specific symptoms, anaphylaxis, inhaled albuterols for bronchospasm, antihistamine for hives. However, only epinephrine, which has both beta-2 agonist bronchodilation and decreased release of inflammatory mediators, and alpha 1 agonist vasoconstriction, decrease airway edema effects, can treat all components of anaphylaxis. Therefore, it takes priority over adjuncts. Okay. Yes. A is patient with anaphylaxis and prominent upper airway edema, oropharyngeal swelling, striatal or voice alteration may require endotracheal intubation. However, these patient respiratory symptoms are from lower airway bronchospasm are mild. Intubation is not indicated. A E Yes, glucocorticoid methylprednisolone are frequently administered as an adjunct treatment for anaphylaxis due to their anti-inflammatory effect. However, their onset is delayed by several hours, and unlike epinephrine, they do not provide immediate treatment for recurrent symptom. And venom immunotherapy is highly effective desensitization therapy for patients with anaphylaxis to B. However, it takes months to years to be effective and is not appropriate. So, venom immunotherapy can be given, highly effective. It takes months to years to be effective. With this time, he will die. Okay, okay.